And the talk today is what happens after the stent placement. Does the stent cure the disease? A lot of people think once you have a stent put in, you're cured and you're going back to your routine life again. But that's not actually true. So I would like to go over some of the things that what you expect after the stent placement. What are the likely things your doctor is looking on a follow-up when you go back to see the doctors, cardiologist, or your primary doctors after the stent placement. Just to give you an idea, what are the underlying pathologies that can happen after the stent placement and why we continue to monitor you after the stent placement. For that purpose, I've divided the problems, what to watch after a stent placement, to 3 different categories. The short term, most of them are procedure-related problems. And the intermediate problems, what happens if the stent does not work well, when to look for it. And the long-term problem, what happens, stent is fine, the area of stent is fine, what happens to the other parts of the artery, and how to change, and what need to be done after that, and what we're looking for to understand the basic pathology of the atherosclerosis, the disease process itself. The short-term procedure-related, site-related problems are mainly if they have done through the groin, through the femoral artery, to be precautions so that you do not have any bleeding there, or hematoma or blood clot formation there, or something called pseudoaneurysm, means the blood clot is formed and then forms a little cavity, still there's opening from the artery into the clot that swirls blood around inside it. That can cause problems, especially if it ruptures, it could be life-threatening. These problems are almost eliminated if we go through the arm, through the radial approach. But a lot of physicians we still do through the femoral artery approach. Things we need to do is mainly to rest and follow the instructions that are given to you by the physicians on discharge. Mainly not to strain or stretch the area of the blockage or to soak in the water to avoid any infections getting in there. And the first 1 week is the critical period to monitor to be careful on the site, so that not to drive in the first 1 week, not to lift any weights, and to get as much rest as you can to the site of the procedure. It applies same thing even to the wrist also, not to drive, not to play golf for the first 1 week after the procedure, even if you go through the wrist. I don't want to spend too much time on this because the more important stuff is what to do, what happens after the stent. Remember, the stent is a foreign body. It's put inside the artery that pushes the plaque to the side with a balloon, and stent keeps the plaque from collapsing into the artery lumen, so that you have a lumen flowing through, blood flowing through the artery lumen. We're not removing the plaque most of the time. They do some procedures where they remove the plaque, called atherectomies, but most of the time we do only balloon and put a stent so that the plaque does not come back into the artery, so you maintain the lumen flow for the blood. So you put this bare metals, it's a foreign body in the blood, naturally the blood tends to clot on any foreign body. What happens if it clots? It occludes completely. Complete occlusions, first thrombus inside the stent. It's a heart attack. It's a serious complication. It doesn't happen often. It's a rare complication. It's like less than 1 to 2% of the time it happens. Most of the time it happens when people do not take their medications, especially the blood thinners, the Plavix or Effient and aspirin. There's 2 medications you need to be on, aspirin plus one of the antiplatelet agents. When you stop taking those medicines due to the cost, or did not listen to the instructions properly, or they could not fill that prescription for some reason, either insurance issues, something, did not take the Plavix and the aspirin, that's when the majority of the problems come in. It's a serious problem. Once you have the clot formation there, it's a serious effect. There's no warning signs on it. It's clear. That's a very important reason why we should not stop. For in case you need to go for surgery or something, they always send them back to me for clearance to stop the Plavix, to know when to stop the Plavix. There's reasons behind it. I'll go over one of them one by one. So this is the main problem in short-term problem, that is. And also they're expensive. These drugs are to be taken religiously without fail. And very important not to miss the medications and follow the doctor's recommendations there. How long you need to take these medications? It all depends on the type of stent you get. The two types of stents basically is a bare metal stent or a stainless steel or cobalt chromium stents that have been around in the market for the last 15 years now, 10 to 15 years. Those stents, they need to be taken, the medication need to be taken only for a month. Why? The normal endothelial layer, or the inner layer of the artery, is called intimal layer or endothelial layer. When we put a stent, this tissue, inner layer, grows on top of the artery and covers it and makes it part of the artery. So the blood is not exposed to the stent anymore. This happens within 3 to 4 weeks in case of bare metal stent or older stents we have. But what is the downside of it? There's the next problem is called restenosis, or reclogging inside the artery, inside the stent. What we do, by putting a stent, the medial layer is a smooth muscles inside this. So when you're pushing the stent, you're injuring these cells or these muscle fibers. So they react by forming a scar tissue, also called as smooth muscle proliferation inside the stent. So what it does is this. They reclog with the smooth muscle proliferation inside the stent. These are the stent struts. You see the little dots? Those are the stent markings. So inside the stent, the smooth muscle proliferation develops like a scar tissue inside it. So recollapses, blocks the stent. This happens in about 25 to 30% of the time with these older bare metal stents. They quickly covered with the body normal tissue, but they have higher chance of restenosis afterwards. And that's why we came up with the medicated stents, which are otherwise called drug-eluting stents. They release these medications slowly over 30 to 90 days time that will prevent this smooth muscle proliferation. In turn, they prevent the restenosis or reblockage of the stents. For the medicated stents, the chance of reblockage is around 6 to 8%, almost 70 to 80% lower than the bare metal stents. That's why we use them more often. What's the downside of the medicated stents? This medication, which is trying to avoid or kill this smooth muscle proliferation, also slows the growth of this normal coverage of the stent. The normal tissue that's inside the artery, it grows on top of the stents, but this medication that's releasing is slowing that process. So the stent is exposed to the blood longer time. So chance the clotting of stent beyond 30 days is still high. So you need to take these medications longer if you received a medicated stent, otherwise called drug-eluting stent. The recommendation for this stents is 6 months to 1 year, or longer for high-risk patients who, if you're diabetic, need to stay on it longer. If you had a stent replacement because of a heart attack, clot formation, you need to be taking higher, longer time. Or if you had multiple stents or overlapping stents, one over the other, then you need to stay on those medicines for a longer time to prevent this clotting on the stent. That's why if you receive a medicated stent, you're not supposed to go for any elective surgeries or dental surgeries for at least a year. That's the FDA recommendation. And also, it depends on what underlying problem you have. Even if you received a bare metal stent or a regular stent in conditions where you had a heart attack, even though for the stent you need only 1 month of Plavix, for that condition of the heart attack, you need to continue these 2 blood thinners, aspirin and Plavix or Efient, for at least a year. Why? Once you had a heart attack, your chance of having another heart attack in the next 1 year is almost 20-25%. Something happening there because the inflammation in the artery in other areas is higher, still there. So to treat the condition, not just the stent, is important in people who had a heart attack for which they received the stent. It also depends on the medical problems the person has. So we decide which stent to use depends on the patient condition and patient plan. Of somebody is planning to go for hip replacement or knee replacement, we know already that they're going to go for the surgery. They cannot wait for a year. Then we go with the older bare metal stents, so they can stop the Plavix after a month or aspirin after a month. If they do not have any planned procedures, we tend to go with drug-eluting stents or medicated stents, provided they can understand the need for platelet therapy, antiplatelet therapy, and they have enough insurance, financial assistance to get the medications. What are the long-term precautions? This is a short-term stent-related, procedure-related issues. By putting a stent in one area, we are only modifying the plaque in that spot only. We're not changing the disease process. What is the disease process? Is atherosclerosis. It is a systemic disease, affects all the arteries in the body, and it is a progressive disease. Very important to understand. It is a progressive disease. The reason it is, a lot of factors depend on the progression, and the genetic background or other medical problems like diabetes affect the progression significantly. And your condition like the blood pressure, if it's uncontrolled, progression is faster. And the cholesterol, if you have a hypercholesterolemia with the familial type, is even faster progression. And the smoking is even biggest factor in progression of disease. Once you have a blockage in one area that's requiring to treat with a balloon or a stent or a bypass surgery, remainder of the arteries cannot be normal. The plaque is worse in some areas where we put a stent, but the remainder of the arteries cannot be normal. They will have some plaque. These plaques in the other areas do progress with time. So the key is to prevent the progression or slow the progression, stop the progression, is the major long-term goal. By putting a stent, my job is done there. But the bigger job is to prevent 100 other plaques from progressing. Worst even, when these smaller plaques rupture, that's when people get heart attack or strokes. So in not only the progression, we need to also to stabilize these plaques so that they do not rupture. The just plaque progression will not give heart attack by itself. When these plaques rupture, the clots on it, blood clots on this raw surface under the plaque, that's when people get heart attacks. Same phenomenon gets strokes too. So we need to prevent this plaque rupture and plaque progression on a long-term survival. That's the key issue. after the stent placement. That's the whole idea of continuing to follow up with repeat stress tests and monitoring you, blood tests, the cholesterol control, your blood pressure control. We follow up after you, that's the main reason behind it. So stents do not change the disease process. They only change the plaque, they modify the plaque at the site where they implant. Maybe a little bit downstream, they might change with the medication flowing downstream. But majority of the time, not change the disease process. Okay. Why do you need, some patient ask me, we treated the 90% blockage, you have another 40% blockage. Why don't you put another stent there? There's no need. Unless it's more than 70% blockage, no need to place a stent or treat that blockage. We have enough lumen reserve for enough blood flow to get through there. They can be treated with medication to slow the progression any further.
Who decided on that?
Based on the angiogram.
Who made that decision?
Why they made the decision?
Who made the decision?
It's the consensus from the AMA cardiologists, Cardiology Association, Vascular Association. The reason being, why 70%? Why not 50%? Why not 90%? Plaque also, when you have a plaque 50% blockage, if you see 50% blockage inside the lumen, if you see the cross section of the artery, if you do a CAT scan of the artery, you will notice it also grows outwards. The plaque not just growing inwards, the plaque also grows outwards. So the artery expands outwards also. For example, you have the artery here. If there's a plaque build up here, there's also enlargement of the outer wall also. So the plaque is also growing outwards, called positive remodeling. They call it positive remodeling. The artery also grows outwards to accommodate the plaque, outwards also, not just inwards, both ways. Once it reaches 70% of blockage, the plaque growing outwards is very limited. So it quickly grows inwards. That means there's no further room outward to expand the artery outside. From 70% to go to 90% does not take too long, because the positive remodeling is already reached threshold. It does not grow outward anymore. So it grows quickly. So that's why the 70% cutoff point comes from. That's what the reason behind it. So the plaque in other areas of the arteries, in the heart and other parts of the body do progress with time. So in order to prevent the blockages or slow the progression, you need to change the risk factors. So until now, what you have done, how you have lived, has not done good to the heart or to the arteries. It's done some plaque buildup and so on. You need to change those risk factors. You need to change your lifestyle, change your dietary habits, with some of them with medications, some of with your lifestyle change. It's not the same. It's not going to be the same. So diabetes control has to be aggressive. The most notorious problem for progression of these plaques is smoking. The worst one of all the risk factors, smoking. Absolutely no smoking, not even exposure to secondhand smoking. Some of the studies have shown all it takes is 1 cigarette a week for this plaques to progress faster. And so that's why the secondhand smoking is equally bad. A lot of times when I see the patients with a heart attack, guess what? I talk to the spouse, they also smoke. In that case, you got to quit. Both of them had to quit. That's a major change for them. Unless they quit smoking, their chance of having another heart attack next 5 years is almost guaranteed. Very high. Aggressive control of the cholesterol. If somebody has no blockages, they have high cholesterol with other risk factors, their goal is different of the bad cholesterol, the LDL. The target goal according to the guidelines is maybe 100 milligrams, or 130 milligrams per day, depending on the risk factors. But once they have a blockage on the arteries, their target goal is way low, below 70. LDL should be below 70. Only two conditions that require that. One is people who have a blockage before, or if they are diabetics. The goal of the target goal for their bad cholesterol or the LDL should be less than 70. Very aggressive lipid lowering therapies, mainly with the statins. There are other medicines which could reduce the cholesterol, but the statins have special other qualities, just not reducing the cholesterol, but they also stabilize the plaque. They reduce the amount of soft plaque there is a core of the plaque. If you see the picture, there's a soft plaque in the middle and then the fibrous core on top. The higher the quantity of soft plaque percentage in the plaque, the higher the chance of it rupturing. The statins reduce this softness in the plaque. They make it more fibrous, more stable, so that they don't rupture often. That's the key. Next important thing to do after the stent placement is exercise. Exercise. The exercise also produces a lot of antioxidants in the body, in the arteries, wall of the arteries, that prevent the progression of the disease. How much exercise need to be done? There's always a question. How much exercise you need and how much, things. The published data studies they've shown that have seen the benefit, the comparing, the cutoff point was 150 minutes per week of moderate exercise, not like aggressive exercise or like athletes, training for athletes or anything like that, not competitive training, but a moderate level of exercise of 150 minutes a week is adequate to see in the